case list? Is it all on the screen?
Mhm.
Okay, cool.
Mic on.
Do you have a certain case that you're worried
Mic
about,
off.
or should I just like go randomly and ask questions?
Um, for me, a lot of these, well, all of the patients I just took care of in the hospital as a hospitalist. So I guess this is more of a general question of, if someone did or did not do something during the patient's prenatal care, how to address that if I wasn't involved in the patient's prenatal care.
You can say that exactly what you're telling me. You can say, I wasn't involved in this patient's prenatal care, but if I was, this is what I would do differently.
Okay, gotcha.
If they've done something that you wouldn't have done, or something that's not standard of care, that's what you should say.
Okay. I think there's a patient on here with myasthenia that could be interesting to go over. I
Which
think,
one?
let me see, it's patient number, or really anything if that you see, I would be fine to go over.
How are you with gestational diabetes? Are you good with that?
You know what? I could probably use the practice.
Okay.
Okay.
And so let's talk a little bit about when somebody comes who has pre-gestational diabetes and early pregnancy, and that could be office or OB. What are the
Okay.
effects of pre-gestational diabetes on the pregnancy? How do you counsel those patients?
So I counsel the patients with pre-gestational diabetes on the risks of both maternal, fetal, and neonatal complications. For maternal complications, her diabetes does put her at increased risk of hypertensive disorders during pregnancy, as well as potentially, if she would require a cesarean, a potential, well, I guess, possibility of postoperative infection. For fetal complications, that would include things like higher risk of miscarriage or spontaneous abortion in the first trimester, congenital anomalies, as well as need for preterm delivery, and possibly also fetal growth restriction or macrosomia. And for neonatal complications, that would include things like neonatal hypoglycemia requiring admission to the neonatal ICU.
Okay, what about congenital anomalies?
So for pregestational diabetes, I think of cardiac defects.
What else?
For some reason, that's the only thing coming to mind right now. I know there are others.
No problem. How do you manage those patients in labor? Patient who comes in with gestational diabetes on insulin, and she presents in labor. They really like to ask this question in the oral board exam, and I personally have been asked this question. How do you manage them?
Okay.
How do you manage the insulin? What do you do if they're an induction, they come the night before, and so on?
So I typically would, well, it does depend on whether the patient's eating or not. So typically,
They usually eat, right? They usually come. Most of them will come,
yes.
they have a meal and they come.
And so at my institution, we actually have a protocol for patients who are on insulin, whether they're pre-gestational or gestational diabetic on insulin, where we actually use an algorithm to calculate the amount of insulin needed. However, one of the easier ways you could do this is just by using sliding scale insulin. Ideally, you want to keep glucose control under 120 prior to delivery. And so you could also put them on half of their regimen, but I don't typically continue a metformin if the patient was taking that.
Okay, well, you're not going to do metformin in labor, right?
Right, correct.
So you're going to have their insulin the night before the induction. That's what you said, right? What are you going
Hmm.
to do when they are like starting to get into labor but not in active labor? And what would you do when they are in active labor? And what kind of fluid would you give those patients?
I typically check, well, I don't typically, I would check their blood glucose every 4 hours in the latent phase, every 2 hours in the active phase, and every hour while pushing in the second stage. And I would avoid D5 if the patient continues to eat throughout labor.
Okay, and what is your target blood sugar?
Less than 120.
Okay. So the patient don't eat in labor, right? You're going to keep them MPO just in case something happens, right?
Hmm.
Everybody's going to be MPO, so you're going to monitor their blood sugar during labor. If their blood sugar is low, then you would give them D5.
Yes.
But what if their blood sugar is normal?
If their blood sugar is normal, then I would have the patient on LR if she needs fluids.
When do you start insulin pump?
So for a patient where I'm having difficulty controlling her blood glucose and it's consistently over 120, that is someone who I would consider starting an insulin drip on.
Okay. And then what do you do after they deliver?
After delivery for a GDMA patient on insulin, I do not continue their glucose. However, I recommend that they do follow up for a 2-hour glucose tolerance test in 6 weeks. For a pre-gestational diabetic, I typically start them on about half of their pregnancy regimen to start, and I do discuss with them that we likely may need to titrate up or down as needed.
Okay. And then you mentioned the 2 hour, but we weren't talking about gestational diabetes. We were talking about pre-gestational diabetes. So when you're
Ah,
answering the exam, just stay focused just to what they're asking and do not
okay,
deviate to something else. Because now that you talked about this as an examiner, if I was examining you, you said that, I'm like, okay, she's not paying attention to what I said. I was talking about pre-gestational. Now she's talking about the 2 hour. So let me ask her about the 2 hour. So what
gotcha.
are the values of the 2 hour test?
Woohoo.
See what you got
uh,
yourself into? I wasn't even gonna
right,
go there. And that's what
right.
happens in the exam. Just you guys be like precise and like to the point and don't say a lot of information. Just say answer the questions and wait for the next one. You'll save yourself so much trouble. Like and that way the question will be just to the point. You'll answer the question and wait for the next one. Even if you're tempted to talk and you know everything about the topic, it's better to do it that way so you don't get into other stuff that you probably didn't want to talk about.
Understood.
Do you know the values? I know everybody forgets those.
So I believe for the 2 hour, I want to say that the 1 hour, I know that over 200 for the 2 hour is diabetes. I cannot remember and I believe between 150 and 200 would be impaired glucose tolerance. Over 200 at the 2 hour indicates diabetes, but I'm having trouble recalling what the fasting numbers are.
Right. So there's two values. The fasting should be less than 126 and the 2 hours should be less than 200.
Okay.
If they're both elevated, then she's definitely diabetic. And that's then you refer her to primary care. But if it's negative, then what would you do? If it's
I
negative, then how do you counsel the patients about following up with, diabetes and screening to find out if she has it in the future? How often should she test in the future?
So she still is at risk for developing diabetes. I
And what
believe
is
I would.
if she asks you, what is the risk? All the patients ask this question. I got it now. What are the chances I'm gonna continue to have it or have it in the future?
I want to say up to upwards of 25 to 50%, but I can't remember.
Right. So over the next 20 years, 50 to 70% of them will get diabetes.
Okay.
Um, so that should be their motivation to take care of themselves and avoid sugary stuff and like be on top of their diet and all that stuff. So
Okay.
if the patient is positive, then she's diabetic. If both the fasting and the 2 hour are elevated, more than 126 for the fasting, more than 200 for the 2 hour, then she's diabetic. If not, then you tell her to repeat her testing every 3 years. If one of them is elevated and the other isn't, then she's impaired. And so this patient would be a good candidate for metformin, nutrition therapy, and yearly testing for diabetes.
Okay.
Let's go back about a couple questions that I asked you. So I asked you about pregestational diabetes and the effects on pregnancy, and you said like fetal, so fetal, neonatal. Didn't you, isn't that what you said? And then you said maternal as well.
Yes.
Okay, so mostly the pregestational diabetes, the focus is on the baby, right? So fetal neonatal, 6 to 12% of those infants will have spontaneous abortion, congenital malformations. Those are increased 2 to 6 folds in pregestational diabetes. And the congenital malformations could be like cardiac, ASD, VSD, transposition. It could be skeletal, CNS, could be like neural tube defects or holoprosencephaly, or it could be caudal regression. Those babies also could be either LGA or IUGR or even IUFD if the blood sugar is really uncontrolled. After they are born, those babies are more at increased risk of RDS, all the hypos, hypothermia, hypocalcemia, hypoglycemia, hypomagnesemia, and hyperbilirubinemia. And so this is another important questions that they like to ask in the exam. And the 2 hour testing after they deliver is also important. And then I asked you about how to manage pregestational diabetes and labor, and how to write an order for an insulin drip. And so the day before the induction, you could have the dose, or you could give her the usual night dose. And then since she's going to be fasting afterwards, you're going to withhold the morning dose. You're going to give her IV fluids with normal saline. And then you're going to start D5 if her blood sugar is less than 70 or when she's in active labor. If the blood sugar is more than 140, then you're going to start insulin drip, and you rate it at 1 unit per hour and titrate it to maintain adequate blood sugar control for about 100 milligram per deciliter. And then you continue to do that, and you check her blood pressure every hour and continue to try to maintain adequate control of the blood sugar and that level. And then after that delivery, if she's pregestational, you can cut the dose to half or a third and just see how her blood sugar is afterwards.
Okay.
If a patient has a pump, it gets a little bit more complicated. The patient controls her own pump, but you initiate it at a rate of 0.5 unit per hour, adjusted from basal rate, and then you have her, like you check her blood sugars and you control it with the patient according to what her blood sugars are. What was the case about the myasthenia that you thought was interesting? Which one was it?
It's down under, I think, renal disease. She just has myasthenia and preeclampsia, so I'm assuming that they're going to ask about, avoiding magnesium and things like that. It is on. Um, where is it? Oh, renal neurological disease, case number 81.
81. Okay. You want to present what you did in the management real fast?
Sure. So this is a 32-year-old G1P0 at 37 weeks. She actually was admitted to the antepartum service in her 36th week of pregnancy with elevated blood pressure. She was diagnosed with preeclampsia without severe features. She stayed on the antepartum floor for a few days, was induced at 37 weeks for her preeclampsia diagnosis. Of note, the patient had a prior history of myasthenia gravis without flares during the pregnancy, as well as pregestational diabetes on insulin, and a history of DVT during this pregnancy. She was a known factor V heterozygote. So during labor and delivery, during induction, she was placed on antihypertensives, as well as monitored closely for any severe features of preeclampsia. Luckily, she did not develop any, and she had a uncomplicated vaginal delivery. Then the patient was placed on postpartum anticoagulation for her history of DVT.
Okay. So you did not need to do seizure prophylaxis for her?
We did not. I just figured that they
Yeah, but if
might.
you did, what would be her options?
So the best information that I can find is either levetiracetam or valproic acid. I have read that phenytoin is not the best option anymore. I would be interested to know if you have any in perception, because a few people I've asked said phenytoin, but I've heard that that's not accurate.
I know you can give diazepam. I don't think there's a problem with that.
Okay.
And you can give amobarbital, but I haven't heard about the phenytoin. It's not the first one that you would give. Ideally, if you're not going to give magnesium, the first thing I would jump into would be the diazepam.
Okay.
So, well, this can come in different ways. Like they ask you if you want to give her something, you're going to say, what was your answer going to be? Was your answer going to be that you were going to give her diazepam, or were you going to give something different?
I was going to do Keppra.
Okay. The diazepam is easier and it's available everywhere, 5 to 10 milligrams every 10 minutes, maximum 40 milligrams. The other options, if the patient like has renal insufficiency or for some reason you can't give her mag other than myasthenia gravis, or maybe they don't have it, there's a shortage, whatever, other than diazepam would be phenytoin, give 300 to 400 IV slowly. And you give amobarbital as well, 250 IV over 5 minutes. But if you're going to do phenytoin and amobarbital, then this patient needs cardiac monitoring for fear of arrhythmia. But I can search up now using phenytoin with myasthenia. You probably researched it. What does it say?
I did, yeah. When I looked on Up to Date was the only place that I could find information on this, because and it says
there is
levetiracetam or valproic acid can be used for seizure prophylaxis, whereas phenytoin can potentially exacerbate weakness and is therefore reserved for refractory seizures.
Okay. So if there's nothing else, then you can use it, but it should not be your first line of giving. So the best medication to give is the diazepam.
Okay.
The other question they can ask around magnesium would be, if there's no IV, how would you give it?
Go
ahead. Sorry.
5 grams intramuscular in each buttocks for a total of 10 grams.
What about if the patient has renal insufficiency? Then you can't give her mag because it's not good for her kidneys. What would you do?
So you could do magnesium maintenance instead of an initial bolus at 1 gram an hour, or you could do a reduced bolus for renal insufficiency, I believe up to a creatinine of 2, after which point you would not want to do magnesium.
Right. So if it's mild, like creatinine elevation, like up to 1, then you can just give like a bolus and a decreased dose. And if the creatinine is more than 1.5, then you wouldn't do you wouldn't do a continuous infusion, but you can do like small boluses every 6 hours with a mag level in between. If the mag level, you repeat it and it's elevated, then you would, if you're giving an infusion, you would stop it and then restart in 2 hours and then check the level again.
Okay.
Before, when I was in residency, we used to check mag levels all the time. Now we don't do that as often, but for those patients, you would need to do that. If they have, problems and we're worried about mag affecting their kidney or for any other reason.
Okay.
Thank you so much for volunteering for the hot seat. I think I'm going to call somebody else.
Thank you.
Thank you. Good luck. Okay. Just give me a minute while I find somebody else on my list for tonight. I have Jennifer. Jennifer Hig 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 Higdon. How do I say your name? Sorry.
Higdon.
Higdon. How are you, Jennifer?
I'm doing well. How are you?
Good. And so what case list do you want to go over? Let me pull up your case lists.
GYN or office, maybe?
Okay. Oh, here you are. Okay, let's do, where's the GYN? Here. Do you have a case on this case list that you are worried about? Want to talk about, or should I just pick randomly?
I think you can just pick randomly.
Okay. Let's look here. Uterine myomas. You have a lot of them. So let's talk, for example, about any of those cases. Let me see here. I'm trying to see in your pre-op diagnosis. You don't mention here if you have counseled the patients about medical therapy, or are they all very huge and causing pressure symptoms on the patients? A topic that they really, really like to ask on the oral board exam is, how do you manage the fibroids medically before you take the patients to the OR? And what do you offer those patients in terms of medical management? Do you have any complications in your case list?
I do.
I'm rolling through it. I don't see much.
There's a relatively complicated one. Here, let me find my paper list.
Which one?
About,
Perforated sigmoid colon?
yes.
Okay. You want to talk about that, or should we talk a little bit about fibroids?
Either is fine.
Okay. I think last time we did talk a little bit about bowel repair and bowel injury. You want to talk a little bit about your case? Let's see, 47. How about you tell us how that happened? Because that's interesting here. I'm pulling it up. Can you
About
present?
the bowel perforation?
Yes, 47.
Yes. So this was a 49-year-old patient who presented to the ER with left flank pain and nausea and vomiting that had been worsening throughout the day. She got imaging, which ultimately showed a left adnexal mass that appeared to be causing left ureteral obstruction, causing pyelonephritis. She had received antibiotics in the ER, but pain wasn't improving, and given her ureteral obstruction, it was felt that she needed to be admitted. Typically, this wouldn't necessarily be a patient that I would admit. However, the hospitalist team didn't feel like her pyelonephritis would improve without removing the obstruction, which they felt like was coming from the left adnexal mass. So they felt like they weren't the right people to admit her. So therefore, I got involved on CT imaging. It was really unclear exactly what the mass was. It appeared similar to an endometrioma on ultrasound imaging. After discussion with the patient, we decided to do a diagnostic laparoscopy, and removal of the mass was the initial plan. However, on diagnostic laparoscopy, when we got in, there was significant pelvic adhesive disease with essentially the uterus, the colon, everything being very consolidated in that area. And so decision was made to stop. This was also in the evening on a call shift. And so that was performed initially. And then there was planning made discussion with the patient's husband that night, and then the patient the next day about going in conjoined with general surgery, and also touch base with urology about placement of a stent to do a hysterectomy and removal of the adnexal mass.
Okay. But they did the whole repair.
Correct. So I had
Go ahead.
touched base with him prior to the day before surgery, and had made a plan that they would be aware should I need them once we got in, depending on how adhered things were on palpation once she was open, and with just trying to pack the bowel, there was already a small serosal tear in the colon, so they came in and took down the adhesions and did repair that.
Okay. So if they ask you here, how do you manage a small bowel injury versus a large bowel injury? Would you know how to describe it? I know we always call the GI doctors to help us, but would you know how to describe it?
As far as actually repairing it?
Correct.
So on a small bowel injury, you would want to repair it perpendicular to the long axis of the intestine to prevent constricting or causing a stricture and obstruction, because you would narrow the lumen if you repaired it the other way.
Okay. Can you give me more details about the repair, or is that all?
Yeah, so typically if it was a full thickness injury, you would want to do a 2-layer closure. I believe that typically silk is used, but I believe more recently there's maybe use of more absorbable sutures. It doesn't necessarily have to be permanent, but that's how I've seen it done, is with silk. And so you'd want to do the full thickness on the under layer through the bowel wall, and then do an imbricating layer on top of that.
Okay. Okay. What if it's a large bowel that is injured?
It depends on the size of the injury. Sometimes it can be oversewn, but if it depends on, again, the size and also location. Sometimes it has to be a resection, which could potentially be reanastomosed, or potentially the patient might have to have a colostomy, excuse me.
Okay. What are some signs and symptoms of unrecognized bowel injury?
So typically these patients present with abdominal pain, fevers. A lot of times they can be peritonitic. They can have nausea and vomiting.
Okay. Okay, so just going over quickly how you repair intestinal injury, and I think I've talked about this also in another caseless defense. First of all, you have to say, I'm going to call the GI doctor, but this is how I know that it is repaired. The bowels should be ran from the ligament of Tritz to the ileocecal valve to make sure that there are no other tears or injuries that are missed. And then you're going to repair it perpendicular to the intestinal exit to prevent stricture, just like you said. And then the mucosa and the muscularis are repaired with delayed absorbable suture, possibly 4O vicryl. The serosa is repaired with 3O silk as a second layer. If more than half the lumen is injured, or if it's if there's like a bovie injury, you're gonna resect and then reanastomose. But if it's less than half the lumen diameter, then you can definitely just do the repair. For large intestine, the repair depends on where it is, on the size and the site. And we're not trained to do the large bowel stuff. That's really more of a general surgeon thing to do. If the small defect is repaired in 2 layers with copious irrigation. If it's a large defect, then they're probably going to do what they did with your patients. They're going to do a diverting colostomy. The same thing they would do a diverting colostomy if it is delayed post-op diagnosis after they close the patient. And then for like, you always have to have like a high level of suspicion for the unrecognized bowel injury if it's after you close the patient, because the symptoms are vague. It could be nausea and vomiting, sometimes abdominal pain, fever, tachycardia, anuria, or any of those things. So it could be really anything. Let's talk a little bit. I don't think they'll ask you more about this. I don't think you did anything wrong. This is something that I think is going to happen with anybody because of what's happening inside her abdomen. So I don't know if you're worried at all at this, but I don't think you should be worried. You have a couple cases afterwards where you had uterine perforation here in case 53 and 54. Can you tell us why you had the perforation, or was it a stenotic cervix, or what was it? Why did you have perforation in those cases?
Yes, in both cases, they were postmenopausal patients who had cervical stenosis. And the first one, I was unable to visualize it really anything once I was able to get in with the hysteroscope, and fluid deficit, I guess, obviously was climbing. And so that procedure was aborted. With the second patient, I was able to call in a colleague who, while it was still difficult to do the hysteroscopy since the perforation was noted early, I stopped that procedure but was able to get sampling with ultrasound guidance. But yes, in both cases, it was stenosis.
Okay. And so is there like a way that you could have prevented this by giving the patient something or helping her something before the surgery?
Yeah, so I'm not sure exactly where she is on the list, but I do have a patient who I gave misoprostol preoperatively because of a similar situation. And we were able to successfully do the procedure. Depending on the degree of stenosis, you could also do like cruciate excision on the stenotic cervix, which sometimes can help get in. I think in these cases, while there was stenosis, the dilation was going relatively easily. And so I think it was given the size of the uterus, and it felt like it was dilating fine, but in reality, it was because there was a perforation. Both were fundal, however.
Yeah, see, like if you're looking at your case list on the screen, case 53, it says here, failed in-office endometrial biopsy. I'm assuming because, of course, he wrote here cervical stenosis here. And so for a patient like this, you should have given her misoprostol the night before and the day off in the morning, and you could have probably prevented, that hysteroscopy to fail. Did you do that on this patient? Because this is a question they might ask you in the exam.
I did not. This patient 57 was one of my partner's patients. Who,
you have a different case?
sorry, 53.
Yeah.
53 was one of my partner's patients who no longer does surgery. And so sometimes he will send his patients to me if they need sampling and he's unable to get in-office biopsies.
Okay. Yeah,
but
so
in retrospect, yes, maybe I should
ask you. You could have prevented this aborted hysteroscopy if you had given her meso the night before and the day off. So why didn't you do that? And you can definitely say what you just told me, that, my partner booked her. I didn't realize this was, going on, that she had cervical stenosis. Had I realized that she had cervical stenosis, I would have probably, recommended doing the misoprostol. How do you normally do it?
I normally just do it the night before, about 200.
Yeah, you can give the night before 200 and also the day of the surgery in the morning, also another 200, or even 300. And then you have the other 154, same thing. Here they can also ask you questions about uterine perforation. How do you manage uterine perforation? They can also ask you questions if you had a perforation from inside the cavity, and you can see it bleeding through the hysteroscope. How can you stop the bleeding? So how would you answer that?
So it would really just depend on the visualization, but I believe if there was bleeding that wasn't being stopped, I would probably feel most comfortable first doing a laparoscopy to see if I could better visualize where the bleeding was coming from and determine the size of the injury, to see if I felt like that would be safely repaired laparoscopically, or that way I could visualize to determine if it was something that was going to stop bleeding on its own. That's
Okay.
where I would start.
Okay. So I think there's a committee opinion on this. How do you manage it, the hemorrhage if it was from inside but not outside? So you answered correctly. You're going to go from the top and see if there's any bleeding inside the abdomen or if it actually perforated all the way through to outside. And if not, that there's a couple things you can do. You can do electrosurgical coagulation from the inside. You can inject vasopressin, 10 units and 30 ml of normal saline. You can do Foley catheter tamponade and wait and see. You can do uterine compression, and then uterine compression. If you're gonna you can do it from the outside and try to do it manually and see if the bleeding stops. Like you put backing from the inside and just massage from the outside and wait and see. So these are some of the things. If she hasn't perforated all the way through, but she has bleeding from the inside, these are some of the options. Hysteroscopy questions. They like to ask questions about different distension media in the hysteroscope, the advantages of disadvantages of using each distension media. So how many types of distension media do we have that we use in the hysteroscopy?
There are a handful. You can use normal saline. You can use LR. You can use sorbitol, mannitol. If you were going to use, I don't typically use those, but I know some people do, particularly if they're going to use like monopolar cautery for some reason. But you have more risk of issues with fluid overload and such, given those are hypertonic solutions.
Right. Okay. So yes, so the electrolyte poor ones, sorbitol, glycine, and mannitol, and then the electrolyte isotonic ones, which are LR, normal saline, and D5. And yes, the fluid overload is much more with the electrolyte poor media. The deficit is up to 1.5 liters, while in LR, normal saline, and D5, the deficit is up to 2.5 liters. Okay, and so what are some complications of using the hysteroscopy?
Well, clearly uterine perforation. Typically, that at least when I've experienced it, it's been prior to actually using the scope, but you can have it with using the scope. You can have fluid overload and hyponatremia. You can have, those are the ones that are coming to mind right now.
Okay, so hemorrhage, uterine perforation, cervical laceration. I think you have a case where you had cervical laceration too. I saw it's on top. Those are some of the complications. Definitely fluid overload, visceral injury if you perforated all the way through and you went into the abdomen, infection, CO2 and air embolism. How do you manage fluid? Have you ever had a case where you had fluid overload?
I have not personally, no.
Okay. Well, how do you manage it if that happens?
So it depends on the patient's symptoms and lab abnormalities. Typically, if they're having like pulmonary edema or pleural effusions, you can give them a diuretic to help with that. you can try and prevent it by keeping a close eye on your fluid deficits, making sure you're not giving them too much IV fluids while in the process, especially if you're doing a more invasive procedure like a long myomectomy. Make sure that you're not going too long on your surgical time.
Okay. The perfect answer would be that you are going to abort the procedure, have the nurse measure the eyes and nose again to double check, and that time you're gonna direct your attention to the patient. You're gonna auscultate the lung. You're gonna give her an empiric dose of Lasix, 20 milligrams through the IV. You're gonna order labs, and hopefully you would have ordered pre-op labs so you can compare. And then what do you look for in the labs?
I see. So you're asking if we are noticing it intraoperatively that it was happening.
Yeah, that's usually what
yeah.
happens, right? When you're doing those cases, the nurse or somebody is monitoring your fluid deficit, right? And then they're going to tell you, exceeded it, please stop the procedure. Now you need to stop. You can't continue.
Sure.
That's normally how it happens when you exceed the fluid overload. Somebody's watching, monitoring the eyes and nose to tell you when to stop.
So you would be looking on the labs for things like hyponatremia or electrolyte imbalances in particular.
Right. So sodium, what would be the level below which you want to repair, or not repair, sorry, correct?
I believe it's 10 less than their baseline.
So if it's less than 120, you want to correct it. How do you correct the sodium?
Using hypertonic saline slowly
Right. And why do you do it slowly?
to make sure you're not getting edema of the brain. I'm blanking on the
Yes, I was doing a mock oral for somebody. It's the same thing. They're like, I know what you're asking, but I can't remember it. So yeah, so if the sodium is less than 120, you're going to correct it slowly. You're going to give 1 to 2 milliequivalent of sodium per liter per hour, no more than 12 milliequivalents in the first 24 hours. And that you do it slowly to decrease the risk of central pontine myelinosis. They like to ask this question. I'm surprised that you've never had fluid deficit before. I remember in residency multiple times I've seen it happen where we've stopped the procedure, like the patient has a lot of fibroids, whatever. We kept doing it, and then we reached the point where like we had to stop, and we stopped. And so things, if they ask you what are some things that you can do or protocols to minimize the fluid overload during hysteroscopy, you can say, I'll get a pre-op sodium and hemoglobin, employ automated low pressure fluid irrigant with continuous monitoring of the fluid. You can inject vasopressin and GnRH agonist in the uterus before starting. That causes vasoconstriction and decreases the chances of fluid overload as a preventive measure. And then you would always give empiric diuretic when you have any deficit, even if there's really nothing much going on. You're going to give 20 IV of Lasix. And then if you think that she is if you hear stuff in her lungs or you hear crackles, then you can give her another 20 or 40. So the most important things are that you're going to stop the procedure, you're going to listen to the lungs, you're going to check the labs, give the Lasix, and then correct the sodium slowly.
Great, thank you.
Absolutely. Thank you. Okay, I'm looking at the list again, and there's a couple names on my list that haven't raised their hands that I'm supposed to call on. So I'm gonna call names, and please tell me if you're available and you would like to do this or not. So I have here Tiffany. Tiffany, hello, Tiffany.
Hello, can you hear me?
Yes. You haven't raised your hands, but did you want to go, or should I call on somebody else?
Yes, I can.
Okay. Okay. Before that, I'm sorry. I'm looking at some people's notes here. Um, if somebody's saying here there's no risk of pontine demyelination after correcting hyponatremia following hysteroscopy because it is an acute hyponatremia, not chronic. I'm not sure of that. What I know is that you need to correct it slowly to prevent the risk, but I'm not sure if it's acute or chronic, if that makes a difference. I think that's Lindsay. You can safely correct more quickly than you stated. Okay. I'm not sure about that. I'll have to double check that, but maybe you're right if you've encountered that case or if you've read more about it than me. And then And then somebody asked me about gestational diabetes. I'm sorry, I'm just looking at the questions right now. Nora said, I thought the practice bulletin mentioned stating an insulin GTT at a blood sugar of 110. So yes, it's between 100 and 110. You're right. Sorry, I just had to answer those before I forget them. Okay, so let me pull up your case list. Tiffany, which one do you want to go over? Let me see where yours is.
We can do whichever one.
This is yours, right? How do I say your last name? Equago?
Oh, it's pretty good. It's Ikwagu. Like,
Equago. That's fine. My last name is El Karaguli. Nobody says my name correctly. Well, I hope you're not offended.
no, not at all.
Okay. And so, which one? You don't care? Should we do office?
Sure.
You have anything in office that you want to go over, or should we just pick randomly?
Pick randomly.
Okay. Let me see here. I'm trying to see. You guys have been doing case list defense. What are some topics that they've gone over recently so I don't go over the same topics again? Have you attended one of them recently?
Yeah, well, yesterday was more like zebras, but we actually did go over like hysteroscopy and fluid overload, and then we did.
Oh, you did all of that yesterday?
Yeah, we did that
Okay,
yesterday.
I'm repeating the same things. We don't know what each other do because it's so random.
Yeah, but it's good you remember it.
Is it the same? Did I say the same stuff that they said?
Pretty much across the board.
Okay, let's do vulvar disease. Let's do case number 23 because you have lichen and they really love lichen in the oral board. So let's just talk a little bit about that.
Perfect.
So if it comes as a structured case and they ask you, you have a lady, let's say a 58-year-old with a white patch on her vulva, whatever, what is your differential? What would your differential be?
My differential would be some kind of autoimmune process, lichen sclerosis. I would also say possible like melanoma is something that I would throw out there. I would also say possible like dermatitis that she could be having, like a vulvar dermatitis.
Okay, so if that's a white lesion, what if it wasn't a white lesion? What if it was like a beefy lesion on the vulva? What would be your differential then?
A beefy lesion,
Yeah.
like chronic lichen simplex chronicus.
Okay. What else?
It could possibly be some kind of like vaginitis that she could be having.
What if she has like a vulvar lesion with pruritus? What would be your differential then?
So that would include some kind of infectious etiology, like
Right. That's
like-
exactly what your case is. It's vulvar pruritus.
yeah. So like lichen sclerosis. I would also include like possible like a yeast infection, we could possibly have.
Okay, let's talk about lichen. So what does lichen usually look like on exam? Because here in your case list, are you still there?
Yes, I can hear you.
I don't know if there's somebody that I talked to that I didn't mute like last time. I'm gonna have to go. I think everybody's muted except for you. Okay, because there was some noise. Okay, so lichen sclerosis, you only wrote your history and physical exam, but you didn't really write what did you see on the physical exam? So what did you see on the physical exam in this patient?
So on my physical exam with this patient, she had a thin vulvar skin. She had evidence of pruritus. Um, she had like a hypopigmentation that was noted around her like lower part of her vagina, her perineum.
Okay. And then how do you diagnose lichen sclerosis?
So with this patient, just given her history and physical, I started her on topical steroids, and then we had her come back and her symptoms were improving. But to ultimately diagnose it, you could always do a biopsy and then send it off to lab and then get the
How do you do the biopsy? What do they call the biopsy plate that they use for that?
a punch biopsy.
Okay. And what would it show under the microscope if she has lichen? Do you know?
No, I would have to look that up. Yeah, I would have to look that up to know exactly.
Can this turn into cancer?
Yes, there is a concern that it could possibly turn to cancer.
What topical steroid did you use?
I use clobetasol.
Okay. And what is clobetasol? What is the mechanism of action? What does it do? How do you give clobetasol?
I gave it to her. It's a topical ointment that she placed. Initially, she placed it every other day for 2 weeks, and then she did it twice a week.
For how long? How long does she do it for?
So she initially did it for a total of 6 weeks, and we came back in to assess her symptoms. And then at that point, I think that you can try to down titrate the amount of medication that you're using to like once a week if your symptoms remain clear, but there's always a possibility that you can have a recurrence and need to restart or up titrate the medication again.
So you follow up with her at 6 weeks, and then when do you follow up with her again?
And then after 6 weeks, I followed up with her 6 months later, and then after that, she would have yearly exams, just because of that possibility of malignancy.
Okay. What are some side effects of using topical steroids?
One of the side effects could be like thinning of the skin if you use it for prolonged periods of time or excessive amount for prolonged periods of time.
Okay. Let's talk about the different kinds of lichen, like lichen simplex, chronicus, or lichen planus. What is the difference? What is lichen simplex chronicus?
Lichen simplex chronicus is where you can have persistent pruritus, and then it can actually lead to thickening of the skin.
Okay, and how do you diagnose? How do you treat?
For that one, for lichen simplex chronicus, you can treat this by like like conservative measures, I believe. So like loose clothing, cotton undergarments, and like ensuring that you have.
Can you give her clobetasol as well, or no?
I believe no, not for lichen simplex chronicus.
Okay. What about lichen planus? What is that? How is that different?
So lichen planus is an autoimmune disorder, and it is, you tend to have like these uh, uh, like red poly lesions that can happen on anywhere in the mucocutaneous tissue. So that could happen not only in the vaginal area, but sometimes you can even see it in areas like the mouth.
Okay. And how do you diagnose it?
And that would also be um, with like biopsy.
Okay, and how do you treat it?
I would also use steroid medication for that.
Okay. What about Paget's disease of the vulva? Do we see that often? Which age women usually have that?
I feel like you would see that in a postmenopausal patient.
Right. Okay. And so what does it look like?
I believe Paget's disease of the vulva would, I'm unsure, I'm blanking right now about what it exactly would look like.
Okay. Why is this more serious than the other diseases that we just mentioned?
The
Paget. Yes.
I believe that has a higher risk of having malignant potential compared to the others.
Right. Where else would there be cancer other than the vulva if they have Paget's?
It could also be in the breast.
Okay, good. What else? Where else?
Um,
So in the exam, if you have lichen sclerosis, they probably won't spend all this time like I did going over all the different lichen sclerosis, or lichen disease and vulvar disease. They'll probably, the most common question, they'll ask you, how do you diagnose it? What did you see on exam? What topical steroid did you use? And then they want to know if you know how to dose it. They'll ask you, how do you counsel the patients about getting the topical steroid, and how often do you follow up with them, and what else do you give those patients, and how long before you see improvement in symptoms. But the reason why I went on and started asking you about the other vulvar disease, because if this comes as a structured case, then what they're going to do is what I did in the start. They're going to say, you have a patient who has vulvar pruritus, what's your differential? And then the next slide, they'll say, you did the exam, this is what you saw, what do you think it is? And then you're going to say, this is, some kind of lichen. And then how do you diagnose it? And then you're going to say, I'm going to do a biopsy. The biopsy came back showing this. And then how do you treat it? And then they can say, okay, well, what if the biopsy came back showing this? Then what's the difference? Then it can go anywhere from there. And so even though it is lichen sclerosis, I deliberately asked more questions just to cover the rest of stuff if they come as a differential or if they come as a case of the day. Let me go over it real fast.
yeah.
So a woman who has like a white patch on her vulva, usually postmenopausal woman, it could be vulvar cancer, of course. That's the first thing you think of. You worry about lichen sclerosis for sure. Could be psoriasis. It could be a lichen simplex chronicus. It could be vitiligo. It could be hyperkeratosis. It could be VIN. It really could be anything. Punch biopsy is always done, and you don't do it in the center. You always do it on the margin. And then a patient who has a beefy lesion, the first thing I think about is melanoma. I think about like a nevi, vulvar VIN or squamous cell carcinoma, because it can be discolored, or it could be Paget's disease of the vulva, because Paget's disease could be, well, they call it like the American flag. It could have like different colors in it. It could have blue, which goes on the darker side. It could have red and white. And so it could be any of those. And then I ask you the differential diagnosis of vulvar region pruritus. Again, the same variety. It could be dermatitis. It could be lichen sclerosis. Could be lichen chronicus. Could be psoriasis, could be Paget, could be cancer. Really, we're going over the same diseases, all of them. Cancer, all the lichens, psoriasis, Paget's, dermatitis, all of them. And then when I asked you about lichen sclerosis, so of course, when you do the exam, you're going to see whitening and some easy bruising. You do a biopsy. The biopsy blade is called a Keys biopsy. You're going to do it around the edge of the lesion. Under the microscope, it's characteristic to see hyperkeratosis, flattening of the red pegs, and vacuolization of the basal layer. It is not pre-malignant, but about 5% of them will develop cancer of the vulva, probably due to irritation and itching and all that stuff. And then you treat it with clobetasol, which is a topical steroid. I ask you mechanism of action. It's kind of an anti-inflammatory. It inhibits multiple inflammatory cytokines. But you don't really need to know that. They probably won't ask you that. That's why when I asked, I skipped. I was like, that they're probably not going to ask that question. Clobetasol comes in a concentration of 0.05% ointment. You apply daily. There's multiple ways of giving it. But the one that I know of, you apply daily for like 6 to 8 weeks, and then after that, you follow up in six to 12 weeks. You see them depending on how long you're going to have them do it, and then you're going to bring them back and see how they're doing. And then depending on how they're doing, either they continue the same, or really most likely they're going to decrease the dose to like 3 times per week or 2 times a week, and then you're going to see them again at 6 to 12 month intervals to make sure it's completely gone. Those patients who are on clobetasol get a lot of candida associated with the use of topical steroids, so you're going to give them fluconazole for that. I then ask you side effects of topical steroids. Those are like those patients, they get exposed to it daily, and you're putting it twice a day or once a day. They can develop skin atrophy, telangiectasia, contact dermatitis. They even can develop Cushing, diabetes, increased risk of glaucoma, decreased wound healing, any of those things. And then for lichen simplex chronicus, I asked you how would you treat. So it's mostly because the skin is irritated. The cause could be an infection, atopic dermatitis, chronic dermatitis. So really, the main thing to do is to stop the irritant. But if that doesn't help and the patient continues to have that irritation, and you biopsy it and you're sure it is what it is, you can also give clobetasol. And then you have to treat the infections with it. Like if she has like bacterial or yeast infection, you have to treat it, and she can also have some anti-itch medication. In terms of the lichen planus, this patient usually have like different lesions. They're even papillosquamous, hypertrophic, or erosive. You also biopsy the same medication. You're going to give her clobetasol, and if it's really bad, you can give her steroids. And in terms of Paget's disease of the vulva, the cancer goes to the breast, colon, and urinary tract. So, and the risk is 15 to 20% for adenocarcinoma of the vulva. And so for the breast, colon, and urinary tract, those patients need screening mammogram, colonoscopy, and the CT of the abdomen and pelvis. And usually in postmenopausal women in their 60s to 70s. And like I said, they could be red, white, or blue in color, like the American flag. That's how I always remember it. And under the microscope, they also have hypokeratosis, but they have foam cells instead of the flattened red pigs in the lichen sclerosis. And then the treatment is what for Paget's?
Steroids.
No, for Paget's disease, you're going to do wide local excision, and they have high recurrence. You need to take it out because there's a high risk of cancer. Okay. Thank you so much.
Right.
Let me call on somebody else. Thanks a lot. Okay. Let's go to Nicole Todd. Hello, Nicole.
Hello,
Hi, how are you?
I'm doing well.
You want to participate or no?
Yes, I do. I just want to preface though that I am on call. I should be okay. I don't have anybody imminently delivering, but
Okay, if
just
you
in
get
case.
called, I'll call somebody else.
Perfect.
Okay, I'm looking at the case list. Can you see my screen?
I can. I did submit a case list, but I don't know if they have it there. I don't see my name.
No, I don't see it either.
Mhm.
Why don't they have it?
I don't know.
Somebody said here, you can either email it to me right now and I can open it. It'll take me 5 minutes to get it. I don't want to waste your time.
Okay.
Or somebody said here that nobody talked about osteoporosis and replacement therapy. Tawana was mentioning the stuff that weren't mentioned. Do you want to talk about one of those? Or no?
Yes. Yes. Definitely hormone. I have a lot of hormone replacement therapy on my office list. So that would be a good one to talk about. Osteoporosis, I could probably use the practice too.
Okay. So I'm not going to do both because I want to take one other person after
Okay.
you. So do you want to talk about hormone replacement therapy?
Yes, please.
Okay. So without a case list, let me just ask you a random question. So if
Okay.
you have somebody come to you who is like, say, 53 years old,
Mhm.
and she's having all those symptoms that are annoying of menopause, how would you counsel her about her options, and what would be your first choice to start her on what?
So at 53 years old, I would start with a history of, does she have any history of previous cancers or any
Healthy. There's
history of,
nothing wrong with her.
okay. So if there's nothing wrong with her, then I usually start by counseling on estrogen, and she has a uterus. I counsel on estrogen and progesterone therapy. Estrogen, I talked to her that a lot of her symptoms are due to the changes in estrogen levels as women get older, and that oftentimes replacing this can give her relief of things like vasomotor symptoms or vaginal symptoms. I talked to her that there are different formulations of estrogen, including oral versus patches versus topical. And I talked to her about the risks and benefits of each of those. And then again, if she has a uterus, I discussed that she needs some form of progesterone supplementation to protect against unopposed estrogen. And we talk about that those formulations are oral versus an IUD.
So let's say the patient said that I hear that they're talking and they're saying hormone. I read somewhere on the internet they're saying that hormone replacement therapy is not good. Am I a good candidate for it? Who would be a good candidate for hormone replacement therapy, and who wouldn't be?
So I discussed that a good candidate for hormone replacement therapy is somebody under the age of 60. And so either perimenopause or postmenopause, under the age of 60 or within 10 years of menopause, who is otherwise healthy with no other major medical comorbidities.
Okay, who wouldn't be a good candidate?
Somebody who wouldn't be a good candidate, again, the opposite. So somebody over the age of 60 or greater than 10 years postmenopausal, or somebody who has a personal history of a breast cancer or a uterine cancer, somebody with a personal history of thrombophilias. That's
Can you tell me what is the Women Health Initiative study briefly? How many arms
so.
in it? What is this study that everybody quotes?
So the Women's Health Initiative was a study where they were looking at hormone replacement therapy, the effects on the heart and cardiovascular health. And they looked at women who were taking just estrogen, and then they were also looking at women taking estrogen and progesterone. And they had different things that they were looking at. As I mentioned, cardiovascular, they're looking at risks of breast cancer, they were looking at bone health. And they were studying these women, and the study had to be stopped because in the estrogen and progesterone arm, there was an increased risk of certain cancers. There was an increased risk, and so they actually stopped. But we have since gone back. They have since gone back and looked and reevaluated some of this data and shown that a lot of the risks came in women that were older, and that's where we've come up with this. The less than 60 or within 10 years of menopause.
Okay. And so if you have a patient who has breast cancer but would like hormone replacement therapy, would you give it to her?
I personally would not.
Okay.
give oral or topical, like a cream or patches.
Okay. And so what if the patient is not a good candidate for hormone replacement therapy? Then what would you do?
So I start off by counseling on conservative behavioral management. So I counsel her that, you know, by exercising, eating healthy, maintaining a good diet, um, decreasing alcohol use, that this has been shown to help with some of the symptoms, especially vasomotor. I do counsel her on some over-the-counter supplement options, and I discussed that some of the non-hormonal options that are available are more looking at treating the vasomotor symptoms, but these include SSRIs and gabapentin.
Okay. And so the SSRIs, what is your drug of choice?
So it would be paroxetine.
Okay. And how would you give it?
So I don't typically give this, so I would have to look up the dosage.
Okay, so what do you give normally your patients whom you can't give hormone replacement therapy?
So I usually start with there's an over-the-counter supplement called S-Equal, and I usually start with that. This is a isoflavin soy derived. I do counsel them that this is not an FDA approved because it is an over-the-counter supplement, but that there is some research that has been shown to be beneficial, especially for vasomotor symptoms. So I usually start with that.
Okay, and so what success have you seen with this?
I've seen a pretty decent success, not as good as for the women that I am able to put on estrogen, but for women that can't take hormones or are preferring to not be on hormones. The company quotes that their data shows that it decreases by 5 hot flashes per day, and I've seen similar to that in my own practice.
Okay, but is there a reason why you wouldn't recommend like any of the other stuff like paroxetine or gabapentin or any of the other medications?
No, there wouldn't be a reason. I just personally haven't had a patient that wanted to go with one of those options. So I just don't have as much experience, but there's not a reason I wouldn't do it. I would just have to look up the dosage before prescribing.
Okay, and so other than paroxetine, how do you counsel the patients about taking an SSRI? What do you tell them some side effects of the SSRI are?
So some side effects include weight changes, decreased libido, nausea, vomiting, headaches. That's all I can think of right now.
Okay, what about gabapentin?
So the side effects of gabapentin, I usually talk about that oftentimes I'll have patients feel kind of dizzy and drowsy while taking it. That's the main side effect that I've noticed that people have.
Are there any other medication that can help with postmenopausal symptoms that are probably not FDA approved but work other than gabapentin?
I believe clonidine has been used previously, but I have no experience with that and would not recommend that because of my lack of experience.
Okay. When you give them estrogen, what is your preferred route of giving them estrogen?
So preferably I do either an oral or a topical cream to the upper thigh.
Okay. What about the patch? You don't like the patch?
Not that I don't like the patch, and I do have a few patients that are on the patch. That's just not usually my first choice.
How do you treat atrophic vaginitis?
With I usually start with a topical estradiol cream.
Okay, what's the dose? How much do you give them?
I tell but I usually have to look up the estradiol cream dose, but I tell them to do half a gram 2 to 3 times a week.
Okay. There are some other treatments other than the creams that are FDA approved. Ospemifene, have you heard of ospemifene?
Yes.
Have you ever prescribed it or like seen any results with it?
I have not personally prescribed, but I do supervise a nurse practitioner who has prescribed it.
Does it help?
Yes.
Okay. Okay, and so they might ask you about ospemifene or Osphena. It is FDA approved to treat severe dyspareunia in postmenopausal women. It's 60 milligrams. It's given with food. Serum agonist, antagonist. Some of the side effects would be like hot flushes, excessive sweat, some vaginal discharge. It is contraindicated in women who have history of DVT or undiagnosed abnormal bleeding. They might ask you about bioidentical hormones, since it's also mentioned in the practice bulletin, and how you counsel the patients about bioidentical hormones. A lot of them will come and say, you know, I read this on the internet or whatever. Gwyneth Paltrow says it's good, or whatever they read on the internet. How do you counsel them about it? What do you tell them?
So I counsel patients that bioidentical hormones is usually a marketing tool, and that they're not FDA approved, and that I would recommend going with the formulations through their pharmacy, and that I do not prescribe bioidentical, and do not that their safety cannot be guaranteed because they are not FDA regulated.
Okay, in the exam, they can also ask you simple questions like, what are some non-medical options to decrease vasomotor symptoms? How do you counsel the patients?
Some non-medical options. I usually talk about lifestyle changes, things like maintaining a healthy weight, increasing exercise, decreasing caffeine, decreasing alcohol usage.
Okay. I'm going to stop here for a minute so I can go over this really, really fast, and then I'll call my last person. This wasn't hard, was it?
I didn't, I mean, I have some polishing up to do, but I felt like I was able to keep up with the questions.
Yeah, you did. You did. And you did a good job. I'm not going to go over everything you talked about. I'll just touch on some things. You did a good job in explaining the Women Health Initiative, and that you prefer, you know, how you counsel the patients. It's important to mention that the transdermal estrogen and the vaginal ring and the gel have low level of systemic absorption, and they bypass the GI conversion of estradiol to estrone, and so it's there's no increased risk of thrombosis. So that is a good you know, a good option to give to patients who are also a little bit like on edge or worried about taking hormone, want to take it but are worried, a little bit worried about taking it. And then I asked you about SSRI, and so paroxetine. I've actually given paroxetine quite a bit, and I find good success with it. 7.5 milligram per day. Some of the side effects are the ones that you mentioned: sexual dysfunction, sweating, constipation, headache, nausea, all that stuff. Gabapentin, actually, you can't prescribe it in all states. Some of them you have to have like you have to be on a register somewhere on the online, so you could you're able to prescribe it, but it is an off use. It's not FDA approved for this, but yes, you can give it, and a lot of patients do find relief with gabapentin. Clonidine is the other one that is also mentioned in the practice bulletin, that is also not FDA approved, but is a good option for patients with hypertension. So if a patient already has hypertension, it might be like a good idea. Probably if you don't feel comfortable managing her blood pressure with the clonidine, just tell your primary care provider or whoever is helping you that there is some evidence that clonidine can help. So maybe they can switch you over to that medication if she has high blood pressure. Otherwise, she might have some like her blood pressure might go down. Osphena, like I said, is one of the FDA approved ones. If a patient has breast cancer and wants you to give her hormone replacement therapy, say no unless you consult her GYN-onc doctor or whoever is managing her, and ask if you can do that or not. Bioidentical hormones, you can tell the patients that yes, they're there, probably work, but they're not FDA approved. There's no well-controlled studies. And also the important thing with all those herbal stuff, that there is lack of standard preparation or dosing. And so the doses in each one of those pills is not like controlled. Like she might not have like the exact dose that she thinks she's taking. And that's why all those medications that are not FDA approved are not really preferred in the exam. Not preferred to give to patients because of the not a lot we know about how it works. Non-medical options would be telling the patient to keep sleeping or living in an area that is cooled down, to dress in layers so she can take out, some layers of clothes if she feels hot. Avoid hot and spicy beverages and food and alcohol. Exercise often. Increase her water consumption, and so on. And I know this is like yeah, of course we're going to tell her to say that, but those questions do come in the exam. I remember I was asked something similar and I was like, are they really asking me this on the oral board exam? Yes, they do ask those questions. There's also another question that's also very similar in osteoporosis, where they say, what are some measures that patients can take so they decrease the risk of osteoporosis? And that would be like putting glides and cleaning up, like not putting rugs in their area so they don't stumble and fall, and not putting stuff in low reach shelf, not on high shelves and stuff like that. I don't think I have time to go over osteoporosis. If we go over osteoporosis, that's probably a good topic for a structured case list. And I'm like 5 minutes out. Does anybody have any questions that they want to ask? I'm looking at the question panel because we have only 5 minutes left. See here, nobody has questions. Natalie, I don't see any unless I'm stuck. Okay. Oh. Wasn't the Women Health Initiative stopped because of cardiovascular risk, not cancer risk? Yes. Did you say that it was stopped because of cancer risk?
Yes, I did. That I was hesitant. So thank you, whoever brought that up, because I needed to look that up.
That is Natalie Davis. She was paying more attention than me. I didn't realize you said that. Yes, it was stopped because of the risk on the heart. And so they stopped that study because it was unethical to continue it. Correct. Thank you for bringing that up. I didn't realize you said that. Okay. Anybody else? I don't see anybody else. Do you have any questions, Nicole?
No, no, thank you for that. I guess I wanted to get your thoughts on, I had brought up Esequal, which is Equal, which is, there is some data behind it, but I know it is a non-FDA approved, and I just thought, would that seem pretty controversial in the exam? Should I, if they ask me about it, I would say, but should I not volunteer that?
Yes, I don't think you should say that.
Okay.
Because it's not mentioned in the practice bulletin, and I'm not sure, because it's also something that is not like, it's a herbal medication. So how good does it work? I'm not sure if you should mention it. Well, probably if you're you shouldn't say it if you're not sure that this is something that you want to bring up in the oral board exam. You can ask questions about what it is and how it works, and that's why I asked you like how effective it is. I wasn't sure myself. Okay, I have 2 more questions. Is fluid overload common with isotonic or hypotonic solutions? I believe it is common with isotonic solutions. It is common with both, but it's more common, fluid overload is more common actually with the electrolyte poor ones, with the hypoosmolar ones, where the fluid deficit is up to 1.5 liters, while in the isotonic solution, the fluid deficit is 2.5 liters. And then there's another question here by Maya. She's saying, is it after age 65 that you cannot offer HRT? Yes, it is not recommended that to offer it after age 65. Now, this is different if this is somebody who had already had it and been on and off it for a while and wants to be on it for a little bit. I think it depends on who the patient, like what her medical history is, but it's not recommended. And usually if she's that way past like age 65, then how did she deal with it all those past years? You're probably not going to start it at age 65. Usually you'll start it in their 50s. So it is not recommended, yes. But there are exceptions. Okay, I think I answered all the questions. Okay. Thank you all for being here tonight, and see you all soon. Night.